Good morning, everyone, and welcome to today's web seminar, Tools You Can Use, Age-Appropriate, Medically Accurate Sexual Health Fact Sheets Available to County Case Managers. We are delighted you are able to join us today. My name is Amy Lemley. I'm the Executive Director of John Burton Advocates for Youth, and we're really excited to share these resources with you today and talk about the important topic of the reproductive and sexual health of youth and young adults in foster care. So we're going to go right ahead and get started and let you know what we're going to cover today. I'll start by briefly introducing a wonderful group of panelists today. We'll look into the reproductive and sexual health disparities experienced by youth in foster care, followed by hearing from a young person, really getting a perspective on from a firsthand point of view. Then we're going to dive into these new exciting fact sheets, which we're excited to share together with a resource for case managers to use those fact sheets. We'll also hear from one county that has really been leading the way in the implementation of SB 89, really kind of what is it like to have these conversations? What is the experience from a county practitioner's point of view? And then we'll summarize by looking at what resources are available for you in your communities, in your counties, in your organizations. And so to share this information today is, again, myself, Amy Lemley with John Burton Advocates for Youth. My colleague, Carolyn Ho, will also be presenting. Leslie LeGras-Morris, who's the director of the LA Reproductive Health Equity Project for Foster Youth. Alexis Berry is a former foster youth and a youth advocate with us here at John Burton Advocates for Youth. Erica Monasterio is the adolescent medicine nurse practitioner, the wonderful person who really led the charge in developing these tremendous resources, and Jaime Munoz with the Orange County Social Services Agency. So that's who you're going to hear from today. And with that, before we start, I want to make sure everyone knows how to participate. First, today's PowerPoint can be downloaded from the handout sections of your control panel, and that arrow points to that. So if you want to download those, you're free to do that. You can also send questions. That's always a very interesting part of our conversation. Please type them in as you have them. Sometimes it's hard to remember once we get to the Q&A section. So go ahead, send them in. You can also type in comments if you want. We'd like to read those too, trying to make it as interactive and interesting as possible. And then all the presentation materials and audio will be posted later today at the link you see. So everything is available, recorded online. Take notes if you'd like, but it's all available for you at a later time as well. And so with that, I'm going to hand it over to Leslie to step us through the first part of today's presentation. Thank you, Leslie, for being on today's web seminar.
Great. Thank you, Amy. I'm really, really excited to be here and to be talking about these fact sheets and guidance. So I just wanted to take a few minutes at the top of this webinar to provide some grounding and context for why it's really critical for all of us to be willing and prepared to have sexual health conversations with youth in the foster care system. So with that, let's start out by talking about pregnancy rates. You all may know this, but nationally, teen pregnancy rates are at historic lows, which is largely due to increased access to birth control and sex education that is medically accurate, at least in California. But unfortunately, the same isn't true for young people in the foster care system who, as you can see on this slide, by the age of 19 are about 2.5 times more likely to have experienced a pregnancy than their non-foster care peers. Next slide. So predominant stereotypes about this issue, the high and disproportionately high rates of pregnancy experienced by youth in foster care, often center on what I tend to call the filling a void narrative. So you might hear folks say, young people in foster care are just trying to create the family that they may not have had, or they are seeking to have someone to love and to love them unconditionally. But like a lot of stereotypes, it ignores recent research, which is documented in the chart that you see on this slide, that highlights a really sobering fact. That more than 2/3 of young people in California's foster care system who have been pregnant or gotten a partner pregnant are not describing these pregnancies as intended or wanted. So it's really important that we don't ignore these systemic issues that are preventing 2/3 of young people in California's foster care system around deciding if, when, and under what circumstances to get pregnant and have a child. Next slide. As you all also know, sexual and reproductive health intersects in really complex ways across all of our lives, but particularly for the life of a young person in foster care. So really unsurprisingly, early and unintended pregnancy has a pretty profound impact on young folks' ability to access and persist in education and employment. So for example, at the age of 19, for young people who had not yet enrolled in higher education, about 1/3 of them talked about accessing childcare being a major barrier. And moreover, by the age of 24, a woman who has a child, her odds of being employed is reduced by 30%, even when we're holding educational attainment constant. Next slide. In addition to the disproportionality in pregnancy rates that we just discussed, young people in the foster care system also experience inequitable prenatal outcomes, which for me is particularly devastating. So as you can see on this pie chart, of young people who reported pregnancy at the age of 17, over 40% experienced a stillbirth or miscarriage, and about 1 in 5 did not get prenatal care. Next slide. So in order to begin to unpack these outcomes, it's really important to acknowledge the intersectionality at play when we're talking about who, from a demographic standpoint, make up the children and youth in the child welfare system. So in California, about 90% of young folks in foster care are youth of color, and about 1 in 3 identify as LGBTQ, which is approximately 3 times the rate of the California general population who identify as LGBTQ. Next slide. It's also critical, as I'm sure you all know, to name and acknowledge the impact of trauma and how that intersects with sexual and reproductive health. For example, stress associated with abuse can trigger puberty to hit much earlier, and trauma also increases a young person's risk of experiencing intimate partner violence. And that experience of intimate partner violence can also lead to their decreased ability to communicate their preferences about contraception and also refuse sexual activity. Next slide. So this slide has more in-depth, detailed data about how the experiences of intimate partner violence impact sexual and reproductive health for young people. But one thing that I do want to specifically point out before I move on to the next slide is that 49% of youth in foster care are reporting forced sex at some point before the age of 19, which is really also important to acknowledge when we consider the drivers of their sexual and reproductive health outcomes. Next slide. So as I mentioned previously, the aforementioned data tell a more comprehensive story than young people just filling a void. There are several systemic and structural drivers of inequity that lead to the outcomes that we've discussed previously. So for example, just 5 years ago, California still did not have yet a state-level policy or training to guide social workers and caregivers on youth's reproductive rights, or provide guidance about how to support the needs of young people as it relates to their sexual and reproductive health. So unsurprisingly, in a 3-county survey that came out around that time, the vast majority of social workers and foster parents reported feeling unprepared to address these issues with young people in their care, and also had concerns such as liability around having those conversations. That lack of guidance or policy has also, in some cases, created scenarios that have allowed practices to flourish that actively infringe on youth rights. So for example, providers not providing young people with private storage space for their contraception. Thirdly, when you think about the multiple placement or school changes that young people in foster care experience, foster youth often have really inconsistent access to comprehensive sex ed in school, and that's something that Senate Bill 89 is intended to address, and we'll talk about that a little bit later. And then lastly, There are some logistical barriers. So for example, providing transportation for youth in foster care to access sexual and reproductive health services. And when you think about 90% of young people in care being youth of color, they also face challenges with provider bias, which can impact the services that they receive and the quality of services that they receive. Next slide. So lastly, before I pass it over to Alexis, I just wanted to briefly share what the Los Angeles Reproductive Health Equity Project for Foster Youth is, or LAREP. So we are a partnership of public and private agencies who have really come together with a bold, audacious goal of ending the inequitable sexual health and reproductive health outcomes for youth in Los Angeles foster care system. So we have multiple strategies that include legislative and policy development, education and training, technical assistance, and public awareness. Our leadership team includes representatives from the Alliance for Children's Rights, Children's Law Center, John Burton Advocates for Youth, Public Counsel, Seattle Children's Hospital, and importantly, the Los Angeles County Department of Children and Family Services, the National Center for Youth Law Services project lead, and we also engage an active youth advisory board that is made up of young people that have lived experiences in the foster care system to make sure that we have their input to inform and guide our work. So I invite you all to visit fosterreprohealth.org to get more information. Thank you.
Thank you very much, Leslie. Really appreciate that. I mean, I know the facts and figures that you present, but when it comes together at one point, it's a really powerful set of information. So thank you for sharing it. And now we're going to turn to Alexis Berry. Alexis entered the foster care system as a young child at 2 and was part of the first cohort of youth to participate in extended care to 21. She's a full-time student at Sacramento City College, and Alexis was really critical in the passage of Senate Bill 89, which requires case managers to help foster youth access age-appropriate sexual health information. She walked the halls of the Capitol and really, helped make the case that we need to take action on this important issue. And so, Alexis, I want to just ask you a few questions. So Leslie went over some of the issues and barriers that create sexual and reproductive health disparities. How do those resonate with you? Do you feel like you were able to access information and services for sexual health when you needed to as a youth in foster care?
Absolutely, and thank you for that information, Leslie, and good question, Amy. So a lot of it resonated with my circumstances. I felt like there were several barriers that led me to not being able to access my sexual reproductive health. In foster care, I was always on the move, living in 9 homes and really attending so many different schools. That caused me to miss out on a lot, including the sexual health education that most teens get while they're in school. So when I missed school from all the placement changes, I was never able to make up that curriculum. In addition to that, I had no idea where to access information besides the internet. And we all know that everything you read on the internet is true. No, not really. A lot of what I learned was inaccurate, and not one of the 7 social workers that I had during my time in foster care even attempted to talk about my sexual health info or care. So the biggest issue with being placed in the different households is that each of the foster families has its own cultural beliefs. In one placement, my foster parent prohibited any conversations about sex and didn't allow us to access birth control at all. So this was a clear violation of my rights, but what was I supposed to do? I was a teenager and I didn't know any differently. So I did not have an unintended pregnancy, but my older sister did. So I got to see firsthand the challenges that she was faced with. She was, she did not plan this pregnancy, but it came, and in a result of that, she was unemployed and moved from shelter to shelter with my young niece.
Well, what would have helped, as you were in these different placements to ensure that you did have access, your rights were respected, and that you had access to the reproductive and sexual health care you needed?
So I think that what would have helped the most would have been having consistent communication about with a supportive adult in my life, whether it be my caretaker, counselor, or social worker. Having a conversation about my sexual health and reproductive rights knowing that my social worker would have been a resource to help me get that sex ed that I missed, or help me get access to birth control that I wasn't allowed to access, or other care and services I may have needed, would have made the world of differences, and I could have made much better decisions around my sexual health.
Well, as you know, Alexis, like, these are really sensitive conversations. I think some adults who work with young people are worried. How can I bring these topics up? Young people don't want to talk to me about these things. In your experience, was that true? Would you have been open to getting this information, or would you found it awkward? I think, what's your point of view on that?
I totally think it's an awkward conversation. It's an awkward conversation for most parents to have with their biological children, but nevertheless, it's a conversation that needs to be had. And I think that once you move past that awkward stage, it would have normalized it. So, having the conversation would have helped plant that seed and normalize that verbiage. I would suggest, that social workers try their best to make it a positive interaction, make it a strengths-based conversation. So, like, no shaming or blaming or anything like that, but make it really strengths-based, and definitely utilize the resources that are language appropriate and learner friendly. And then, in addition to that, while we're going through this process, really gather feedback from the youth that they're interacting with to see how they can improve the training ongoing.
Well, those are really great recommendations. I think there's a really big appetite for the information you're sharing. And I do think people want to have those conversations, but they also want support to have them. I was saying before we got on, we had over 600, almost 700 people register for today's web seminar. So I think that there is a thirst, a hunger to know how to have these sensitive conversations, but these important conversations. Before we wrap up and move on, Alexis, is there anything else you'd like to share, with the group that we have on today's web seminar about this important topic?
I just want to say thank you, and I appreciate everyone's willingness to be open and wanting to indulge in more information and to better provide service to our vulnerable population, because it's a much needed piece of education. And I think that together we can work to help young people make more informed decisions around their sexual reproductive health. But it all starts with people who are willing to actually take that step forward and engage. So thank you all for being on the call.
Thanks, Alexis. Really appreciate your time very much, and all the work you put into SB 89 and all the work you're putting into the California Homelessness Coordinating and Financing Council, where she was appointed by the governor to serve on that body. So lots of important messages she's bringing to people about a range of issues impacting transition age youth and foster youth specifically. And so the information that Leslie presented and the firsthand perspective that Alexis shared really came together 2 years ago to work towards the passage of a bill, Senate Bill 89, the California Foster Youth Sexual Health Act. And it was championed by Senator Connie Leyva, a wonderful champion for the rights of foster youth, and specifically around their sexual health rights. And as you can see on the slide here, we're not going to go into depth on this. I'm only going to highlight it to the extent that it relates to these fact sheets. The goals are improving access to sexual health education, informing youths of their rights and removing barriers, and then ensuring the adults in the lives of foster youth are well trained on what their obligations are and what the rights of youth are. So just a word about the improved access to sexual health education. The first provision of the bill requires case managers to verify and document in the case plan if the youth age 10 or older has received comprehensive sexual health education once in middle school and once in high school. And so around the state as we speak, we have social workers doing that verification and documentation. The goal here was really to close that loop to say, young people who need this most, we need to make sure they're getting it. If the young person has missed it, it has to document how the Child Welfare Agency will ensure the youth receives it. So that's the first part of the bill, and but not the main focus of today's web seminar. This second provision truly is That is the informing youth of their rights and removing barriers provision. And so it does require the case manager to document that they've informed youth age 10 and older of their sexual health and reproductive health rights annually in an age-appropriate, developmentally, medically accurate manner. And those 3 boxes are the 3 specific pieces of information that they need to include. The right to access information, the right to consent, and how to access, including helping a young person remove any barriers. So it's both informing and removing. Those are the 2 main verbs, inform and remove. And so this is, again, for every youth in care, 10 or older, including non-minor dependents. And that's a whopping like 22,000 young people annually. So these conversations, SB 89 has been in law for 2 years now. The ACL came out about a year ago. So these conversations are already happening around the state. And the point of today's web seminar is really to give tools to support that communication. And that's what we have today is, as part of LA Rep, we've developed a series of youth fact sheets and an accompanying case manager guide that really is intended to get these conversations started in an age-appropriate, developmentally accurate approach. And that includes tweens and early adolescents, middle adolescents, and then transition age youth and young adults. And we were delighted to partner with Erica Monasterio in the development of these important fact sheets. The slide in front of you tells a little bit about her, but we really couldn't have had a better person to turn to who had a really unique combination of expertise in adolescence, reproductive and sexual health, and so we were delighted to be able to partner with her on this. And so at this point, I'm going to turn it over to Erica, who is going to walk us through these great fact sheets and the case manager guide. Thank you, Erica, for being on today's web seminar.
Good morning, everyone. First, I just want to say I'm really honored to be able to have participated in this process. As a primary care provider working with youth in detention, foster youth, homeless, and runaway youth, I've seen the negative health impacts of lack of information and lack of access, and how that results in often unintended pregnancy, sexually transmitted infections, serious outcomes that are problematic to the young people that we're trying to serve. I also want to reassure you as case managers that if you're feeling uncomfortable with this content, join the club. I have given innumerable talks to parents in PTSAs, to CASAs, working with the foster youth programs in San Francisco, to foster parents, to group home staff. No adult feels super comfortable talking with teens about sexual health. So it's a skill, you can develop it, you can develop comfort, and I want to reassure you that with time and good intention, you can do a great job with this. So I wanted to give you a little bit of background about the fact sheets so that you understand how they were developed. So first, just the principles. I tried to really utilize the Centers for Disease Control's plain language guidelines. So this is avoiding medical terminology, trying to keep the concepts accessible to individuals who have limited health literacy. And adolescents, by definition, have pretty limited health literacy often, and certainly foster youth who often have a story very similar to Alexis, where she had difficulty accessing information, didn't get it at school, etc. That really impacts on their health literacy as well. So we tried to use these principles. All of the youth fact sheets started out written at an elementary reading level. Now, through the process of feedback, some of them may have wandered up a bit. That's the tendency, especially as you try to make things less wordy. Sometimes they get actually more complex. But the reading level was originally set between 3rd and 5th grade. So as I mentioned, some of them, particularly the transition age youth and young adult one, may have wandered up. And over time, young people do develop more skills, including their health literacy and literacy skills. We also tried to really prioritize the developmentally appropriate concerns for the age group. So as you look at the information sheets, you'll see that the content is essentially the same, but things that are pulled out and emphasized for younger adolescents are different than those for older adolescents. But each of the information sheets is designed to reinforce the information about SB 89 sexual health rights, as is required by the law. They're really designed to support a conversation between the caseworker and the youth in foster care. They are not designed to replace it. So the idea is not that you have these wonderful sheets and you print them up and you say, oh, and here's your sexual health rights, and hand the young person a piece of paper. Really, the piece of paper should be looked at together or follow the conversation, but do not replace a conversation. And each of them has resources that are age appropriate, and I'll give you examples of those as we go through this. Some of the resources we didn't have any choice about. There are some excellent resources about health rights, foster youth health rights, that are really written for individuals who can read fluently, have a higher reading level, and those they're great resources, but may not be that accessible to younger adolescents, and certainly not to tweens. So there's things that you might want to read through with your client. Next slide, please. So I also wanted to just reassure you in terms of the process that this wasn't, Erica going into her dark corner and making these things up, that there was a very iterative process that went on. And these sheets were, the youth information sheet, fact sheets were reviewed and modified based on feedback from social service professionals, from legal professionals, and from current and former foster youth. And you can see images of them down there, and you can see how they kind of progress in terms of even the visuals on them are developmentally appropriate. Next slide, please. So we also developed a guide for you all, the case managers and social workers, probation officers, and the principles that we used for this guide were first to start from a trauma-informed perspective. And I cannot tell you how resounding the feedback was from youth currently and formerly in foster care, that they really wanted the individual talking with them about these things to see them through a trauma-informed lens, and we'll talk a little bit about that. These offer guidance and resources to support conversations that really target appropriately the age group and developmental stage of the young person that you're talking with, and again, emphasize a trauma-informed perspective. They are focused on sexual health rights, so they do not include other health rights that youth may have. For example, in California, the right to seek mental health services. They're not addressed in these sheets because these sheets focus on SB 89. But it would be very important for you as case managers to integrate that other information as well as appropriate. Each of the case manager guides includes conversation starters for each developmental stage, so that you can have some ideas of how you might open up a discussion of these, the mandates of SB 89. Again, they're designed to support a conversation between the case manager and the youth, using the fact sheets for the youth as a resource and reinforcement for the conversation. And they consistently identify the case manager as a resource and encourage young people to seek adult support while informing them of their rights to confidential care. So the message is not, go out and do this on your own, although legally you can. The message really is, I'm here to support you in this process in any way that you need or desire support, or that I can contribute to your process. Next slide, please. So this is, you can see a little image down here of the case manager guide, again, related to the process of the case manager guides. These were reviewed and modified based on feedback from legal professionals and child welfare professionals. We had a wonderful session full of information and concerns that Leslie facilitated with over 60 social workers from LA DCFS. And then we had paper review by various county professionals involved in healthy sexual development in foster care. So we really went to the experts and asked them, does this meet the need? How can we change this to be more inclusive? Where should we, where should we put more work? Where can we make it assume that people know things? So we got a lot of feedback and did a fair amount of modification based on it. Next slide, please. So I just, in respecting both where we're at in terms of our work with foster care as professionals and the voice that we heard consistently from foster youth, is that we need to remember the impact of trauma. And that by using a trauma lens, we can really facilitate very difficult conversations that we need to have with young people. Now, when you look at visuals like this of the impact of trauma, they look kind of doom and gloom. And so I want to emphasize also that we know that resilience trumps trauma, that with adequate support, with guidance, with love, young people do very well. Young people in foster care do amazingly well. And without those things, they have really challenging outcomes that they may encounter. And so I want you, as you look at a graphic like this and look at issues particularly that might impact on your interaction with them, their cognition, their physical health concerns, their emotions and difficulty in regulating emotions, their relationship issues, and whether they can attach with you or even trust you. Their mental health issues that can lead to them really being paralyzed when faced with conflict or problems or unexpected outcomes. And the behavior that they may manifest, which for any person around them may be somewhat off-putting, to remember that this is often based in a history of trauma and the coping skills that they have worked hard to develop that may not be healthy and productive, but have protected them through difficult experiences. Next slide. So the 4 R's of trauma, and this is really based on the work that the work that SAMHSA has done in trauma, but there was a recent, just last month, publication in Child Trends that pulled this out with this very lovely graphic, is first to realize how widespread trauma is and the impact that it has on the clients that you serve. And certainly by definition, the young people you are serving have experienced trauma. To recognize that sometimes their behaviors, their attitudes, the things they do, the challenges that they face are grounded in the trauma that they have experienced. They are symptoms of their trauma. And to also recognize that we as caregivers, as professionals, are also impacted by secondary or vicarious trauma and need to learn how to take care of ourselves and not take it out on our clients or just burn out and decide to leave. The 3rd R is to respond. We really need to integrate what we know about trauma into our policies, our procedures, and our practices. And so you'll see in the case manager guide that the front end really talks about the impact of trauma and how it may affect the conversations we're trying to have with our clients. And finally, to resist re-traumatization. This is an important thing to think about because for a young person who's experienced sexual abuse, which many of our clients have, talking about sex and sexual health can be re-traumatizing. So be sensitive to that. It doesn't mean that they don't need the information, but they need the information with an acknowledgement that this can be difficult, it can be painful, it can stir up difficult experiences. It also can be mirrored in their current relationships. So as Leslie pointed out, the rates of young people in foster care who have problematic relationships, even abusive relationships, is much higher than the general population. And it's quite high in the general population as well. So just be aware and always stick to that do no harm. If it's too difficult a conversation right now, that's okay to put it on hold, to deal with the feelings in the room, to provide support, and then to follow up later when the client's ready to discuss the issues. Next slide, please. So some trauma-informed approaches you may want to think about. First of all, each young person that you're working with is an individual and is unique, and you need to individualize your approach to meet their needs. You need to work to earn and maintain a trusting relationship. Trust is hard to engender. People who have been betrayed by those that they should have been able to trust the most, which is many youth in foster care, have a hard time developing trusting relationships. Discussing confidentiality and situations that might result in the need to breach it, because we do not ever provide, including in medical care, complete confidentiality. It's always conditional. It's an essential step of building trust so that the youth doesn't feel betrayed if information surfaces that results, for example, in child abuse reporting. Acknowledge that this is a hard conversation to have and recognize the trauma symptoms that might interfere with your conversation. Ask the youth permission. They may not be ready to discuss this at the time that you wanted to. And they may need additional time or additional sessions to really have a full and comprehensive discussion. And finally, and probably most importantly, is don't waste your precious time telling them things they know. Use a strength-based approach. Build on what the youth already knows. Recognize their attempts to protect their sexual and reproductive health, even if they have not been effective. Most young people are doing something to try and protect their health. So recognize those things and explore and support their desires and choices. It's not our position to judge or to make decisions for them. It's our job to really provide them with information and resources to make the best decision for themselves. Next slide. You also need to prepare yourself. So take a look at your own attitudes and biases. We all have them. If you think you don't, take a second look. Remember that these are your clients, not your children, and what you might wish for your own child is not the reality generally of the clients that you're serving. So you need to, take a look at your own attitudes and check them at the door. Make sure you are updated in terms of your knowledge about sexual and reproductive health, but know that you don't have to be a subject matter expert and that the information changes frequently. So it's always a great thing to say, wow, I don't really know, but we can find out together, or let me try and find that out for you. I'll get back to you. And if you promise to get back, you absolutely need to respect that promise that you've made. Make sure that you're familiar with the law and understand the youth's rights around minor consent and confidentiality in California, and review the resources that are included in the youth fact sheets. The great thing about good health education is that it's a great tool for providers as well, and I'm including you all in that word, providers. It's a great way to think about how to frame a conversation, what level the language should be at, and what concepts might be most salient to the client that you're speaking with. Next slide. So this is a resource for both the youth. There's a link on the sheet, the information sheets for them, but also for you as case managers. And John Burton Advocates put this together. It's a kind of one-stop. You can see there are the tweener middle school, teen or high school, and transition age youth, young adult resources. Even though the little boxes look the same, they link to different resources. And then there's a fourth column that's specific to Los Angeles County, that because LA has made a big investment in this process and has specific developed resources for youth in their county. Next slide. So we're going to run through a couple of scenarios just to take a look at how you might broach the mandates of SB 89. In the guide, there are conversation openers, even for when you're starting from nowhere, like nothing came up, there's no bridge into the conversation, a way to open it. But I thought it would be helpful to really look at this issue of teachable moments and how you can integrate this into the services you're already providing. It doesn't have to be a standalone conversation or something that's awkward or uncomfortable or unrelated to the work that you're doing with your client. So this is a tween early adolescent scenario, and as you can see, there are some ages for biological males and biological females at the bottom. These are variable and fluid, so age does not define where a youth is at developmentally, but it does give you a cue. So let's start with James. James is an 11-year-old in foster care since the age of 5. He asks his case manager if she can help him get new clothes and shoes because he's growing out of all his clothes. His case manager, realizing this is a great opportunity to talk about puberty, which is one of the real concerns of tweens and early adolescents, probably the biggest concern, sees this as an opportunity to review the requirements of SB 89 and says, I can definitely help you with getting clothes and shoes that fit. If you're growing taller, your body is probably changing in lots of other ways too. Have you learned about puberty, the body changes that happen as you get closer to being a teenager from your foster parents, friends, or at school. So really trying to get at that question of if they in middle school they've already had some sexual and reproductive health education, or whether maybe they missed that, or unfortunately, even though that is the mandate in California, not all counties are doing it in middle school. Next slide. So these are some characteristics of tweens or early adolescents in terms of their development. In the guide is a more detailed chart, but the things I just want to point out are sort of what's bolded here. Their big question is, am I normal? And their definition of normal is like everybody else, and it's what they imagine everybody else is like. They become very concerned with body image and privacy. Their bodies are changing, and they become much more private and sometimes secretive about what's going on with them. It is developmentally normal to begin separation from their family or caregivers, and there's some increased conflict in terms of them trying to sort of assert some additional autonomy. They are very self-preoccupied. They have very active fantasy lives. They tend to hang out with same-sex friends and engage in group activities. They can be extremely moody, kind of Dr. Jekyll or Mr. Hyde. They are beginning to really concentrate on relationship with peers, and they are very concrete thinkers. So they're in the present, here and now. What I've experienced, what my friends have told me is what matters. So they're not usually that interested in data, facts and figures. They want it related to personal experience. Next slide. So coming back to James, and this applies not just to your conversation with James, but your conversation with any of any youth that you're trying to have these conversations with. First, remember, you do not have to talk about everything in this session. It's not a checklist that you need to make your way through. Make sure that you share information and resources, because sometimes the youth is so embarrassed or uncomfortable that they can't, all they hear is buzzing in their ears. They can't really take the information in, so they need to know where they can get the information on their own. Acknowledge that it can be embarrassing or hard to talk about sexual health, but that you're here to do it. You're comfortable, even if you're not actually that comfortable. Portray to them that you're feeling comfortable, informed, and ready. Make sure you ask permission to discuss sensitive topics. Don't just go barreling into them. Do not make any assumptions with any of your clients about their sexual orientation, gender identity, or sexual behaviors. If it's information you need to know in order to understand them better or to assist them appropriately, then ask. Give James, or in the other scenarios, your middle or late adolescent client, the tweens, early adolescent, or appropriate sheet, and review it with the client. So again, it's not just a sheet and then you hand it to them and then you can check the box. And most importantly, let James know that you are a resource for him to learn more about his growth and development, his sexual and reproductive health, and his health rights. And this slide about continuing the conversation with James really applies to all the scenarios we're going to discuss. Next slide, please. So this is just a sample of one of the resources that is available on the Tweens Early Adolescent sheet and on that link in John Burton Advocate's website. And they're all videos, they're funny, you can see some of the topics: sexual orientation, gender identity, personal safety, healthy relationships, STDs and HIV, pregnancy and reproduction. And the one that is covering up is puberty, and these are some of the puberty videos. They are very appropriate to the younger clients and very helpful for you as providers to take a look at. Next slide, please. Okay, so let's look at a middle adolescent scenario. And here again, you have the ages for typical development for biological females and biological males. So Sandra is 15 and living in a group home. When she meets with her case manager, she tells him, "I think I might be pregnant, but I don't know for sure. What happens to my placement if I'm pregnant?" Her case manager realizes that she needs information about her sexual and reproductive health rights and says, "I'm so glad that you felt comfortable enough to ask me about this. Let's start with the basics. It sounds like you may need a pregnancy test. Do you know how to get one?" So you can see here demonstrated that validation, acknowledgement, and an attempt to build on what the client already knows. Next slide. So these are some characteristics of middle adolescents. They are much less concerned with am I normal and much more concerned with am I attractive. They are experiencing an increased drive for independence from their family and caregivers. Peer groups become really the most salient point of reference for them. They are experimenting with relationships and sexual behaviors, and this is normative adolescent development. They're moving towards forming and solidifying their sexual orientation and identity. And most have some increased abstract thinking, but they have a really hard time applying what they know and can talk to you about to what they do, particularly in the realm of what we call hot cognitions, or in the heat of the moment. Next slide. So with Sandra, she tells her case manager that she usually goes to a doctor that her group home uses, but she doesn't want her group home staff or other girls living there to know her business. This is a good opportunity for a case manager to discuss her sexual health rights that are guaranteed by SB 89, starting with her consent and confidentiality rights. So you can see in this case, what's appropriate is to talk about that, not to talk about whether you got sex ed at school right now. Not that you don't need to get to that, but it's not where you would start. So perhaps saying you can go to a doctor or clinic for a checkup, a pregnancy test, or birth control, and you can get this care on your own without asking permission from the staff at your group home. If you go to a doctor or clinic, the things that you talk about that have to do with sex, pregnancy, birth control, or diseases that you can get from having sex are between you and the doctor or clinic staff. It's what we call confidential. Next slide, please. So this is a sample of resources for middle adolescents, and you can see they're quite different graphically and in every other way from that is available to early adolescents. And again, they're just chock full of great information and advice and decision-making trees and tools for young people that are very useful for providers as well. Next slide. So let's finish up with a transition age youth, young adult scenario. And again, we have here the age range, remembering that ages and stages are variable. And we've put here 21 plus because, as you're probably aware, although physical development by now is complete, cognitive development, brain development extends into the mid to late 20s and even up to age 30. But by most research at this point, probably between the ages of 26 and age 30 is when the frontal lobe is fully developed. So areas around reasoning and decision making, impulse control, these areas of the brain are still developing in your transition age youth. Janae is a 20-year-old. She's a non-minor dependent, and she has a 2-year-old daughter. She's meeting with her case manager to discuss housing options and mentions that she ran out of her birth control pills. She says, I know I should be able to figure this out, but there are so many things to deal with. Her case manager identifies an opportunity to review the requirements of SB 89, starting with the case manager's role in mitigating barriers, and says, even when you know what you need and where to go for care, things can get in the way. If you need help figuring out your insurance or payment for care, transportation, childcare, or anything else that's keeping you from being able to take care of yourself, talk with me about it. I'm here to support you in taking care of yourself. Next slide. So some characteristics of transition age youth and young adults is that they are moving towards autonomy. They, if they are going to obtain abstract thinking, they have become abstract thinkers and have some useful insight into their own situation and needs. Their sexual orientation is nearly secured. Their body image and gender role definition is also nearly secured. They are more emotionally stable. They can express their ideas in words. They're beginning to think beyond themselves and have a sort of more general worldview. And I think Alexis telling her story and telling us about the work she's been doing is a great example of where transition age youth and young adults evolve to. They do have greater skills around intimacy, and they're concerned about their future. And they're also concerned about their transition to adult roles, whether that be school or work. Next slide. This is an example of one of the resources that's available on the TAY Young Adult resources. This is a birth control choice website where they can put in their interests, experience, concerns, medical conditions, etc., and sort through what might be the best choice for them. And again, this is fact knowledge-based. It is a very highly reputable source. It has resources for both patients and providers. So patients, sorry for you all clients, and providers, although it's medical providers, if you want some of the more details about the methods, you can find them there. Next slide. So just to sum up, using these resources, the conversation starters are just suggested approaches. They are not scripts to memorize. Think about your own communication style, your relationship with the client, try out different approaches, find what feels comfortable and natural to you. Because when you're uncomfortable, your client senses it, and they are going to assume your discomfort is with them, that it's judgment, that there's something about them. Oh, do I have, egg on my face? Do they think I'm a bad person? So you want to look and feel comfortable. Use your own words and approaches. Leverage the teachable moments, just as the little scenarios showed. There's often an opening in the conversation, a question that your client asks. That's a great segue into talking about the mandates of SB 89. So you don't have to always do a cold start. Build on what the youth already knows. Ask questions and use active listening skills to determine their learning needs. We all are pressed for time. We're all overwhelmed by the number of youth that we serve. Don't waste your precious time or theirs telling them things they already know. Really start with learning what they know and what their information needs are. And finally, be not only willing, but enthusiastic about learning alongside your clients. Sexual and reproductive health is rapidly changing. The methods change, the amount of time they can be used changed. So you want to stay up to date. And if you're not, just say, I'm not sure. Let's find out together and utilize the resources that we've provided to you or those that your clients might use. Okay, next slide.
Thank you, Erica, so much for your work in developing the fact sheets and your presentation today. We appreciate it so much. And we're very excited now to turn to Jaime Munoz, who is with Orange County Social Services Agency. Orange County, I would certainly count as among a leading county in supporting the healthy sexual development of young people in foster care. He's an administrative manager, too, at the Social Services Agency, and been really working to press this issue in the county and statewide since December 2014. So thank you, Jaime, for being on today's web seminar. We really appreciate it.
All right. Thank you, everyone, and happy Thursday. Thanks for being on this webinar. We've heard Leslie and Alexis speak about the urgency and the reasons why to support our young people in developing their healthy sexual development. And we heard Erica offer some exceptional guidance on how to engage youth. And so I hope to offer you an organizational structure approach to move this forward. And so on the first slide, you see what we call our living guiding blueprint. And we started this work in December 2014, and we continue in this work. And this blueprint, what we did is we convened a group of community partners invested in supporting healthy sexual development. And we identified some impact points. And it was important for us to identify these impact and we identified accessible objectives to accomplish, to impact each of those, to support each of those individuals. And you see our plan there. What's remarkable is that this plan we developed at the beginning of 2015, and it continues to be as relevant as then. All right, let's go to the next slide. In the next slide, so these are some reflection points to consider. One thing is it takes time. So everything we're hearing today, we want to implement immediately. But it's important to set your expectation and your awareness that this will take time. It's a lot to change a practice, and there's a lot of other variables. Social workers, probation officers come in, retire, move to other opportunities, and then we're also dealing with humans who have different abilities and responses to engaging youth, supporting youth in their sexual development. And then the other part with that, it does require stewardship. And so in Orange County, what we did is we convened a steering committee comprised of individuals from our child welfare department, but more importantly, individuals from our community who held us accountable and to task in moving forward, and who offered guidance and resources to advance our efforts. Another point to consider is that it's important to collaborate. So do not keep it as an internal responsibility, because it's not just an exclusive internal responsibility for probation or child welfare. Collaborate with your community partners. What that will offer is you have internal influencers, but you also need those external influencers who will push you in a better direction, and who can also step in to defend different types of drifts or challenges to advancing forward. We also recognize that it's not all about sex. And so when we pulled ourselves back to look at what is the best way to support sexual development, and we realized that a connected youth is a youth who then begins to shape a future outlook, who then begins to inform their day-to-day decisions based on that desired future outlook. And then that is a strong influencer as to when they feel ready and will begin to form their family if they choose to. And then with that is just the importance of the youth being connected. And it reminds me of this quote that says, you know, being deeply loved by someone gives you strength. And so that's what is most important, I think, for our youth. Next slide. And so the next slide offers some ideas on how to implement some of the tools that were presented today for you. And so the most important thing is to get these valuable tools in the hands of those that can use them immediately and who can benefit from them. And so first and foremost is our young people. They need to have these tools. And then so you need to think about how are they going to access it. In Orange County, we did hardwire some practice. If you recall in the earlier slide, there was that blueprint. One of the first things that we did was to publish a policy on sexual reproductive health, because in December 2014, we had no policy on sexual health. By September of 2015, we had a policy, and we felt it was important to hardwire certain practices. And so one of the practices that we hardwired was that a social worker would engage a youth no less frequent than every 6 months in discussing their sexual health rights. And so this is a great opportunity for us to then add this additional resource to share with you. We also do an annual sexual health resource fair for our caregivers, our service providers, and for our youth. And so there's another opportunity for us to be able to offer these new resources. And then occasionally we'll do an awareness month, like for instance, May is Sex Ed for All month, and to build awareness about sexual health. And so that would be yet another opportunity to offer these new tools. And then, of course, you can post them on your website. If we move to the next column, I'm also interested in our social workers being more aware of these new tools. And so we also hardwire training for our social workers. So all our new social workers receive training on sexual health rights for foster youth. And then we offer ongoing training, and we offer different types of trainings. They can be as short as 30 minutes, or they can be as long as a day. And some of them are offered by social workers, supervisors, nurses, and others are offered by current or former foster youth. And this would be another way to provide the tool. And I love the point that had been mentioned is social workers do not, and probation officers do not need to be the subject matter expert. And when you clarify that at the beginning of any training, their minds are much more open to receive and the information and to begin to discover their own practice on how to engage and support youth. Our caregivers will also be would benefit from these tools, and so look at opportunities to put these in the hands of caregivers. For us, we have a bi-monthly or quarterly newsletter that goes out to all our caregivers, and so that's on my to-do list to make sure that we announce these new tools to all our caregivers via our effective newsletter. Our caregivers are also invited to all our other activities, and so that would be another way for them to receive it. The fourth column has to do is how do we get these in the hands of service providers? And so as I mentioned earlier, we have a steering committee, and it's a pretty robust network of providers, and so this is going to go straight to them after this afternoon once they're posted on the website so that they can immediately begin to use these tools. And then finally, our influencers. And so in Orange County, we have some really good friends with the Juvenile Justice Commission, for example, who takes a strong interest in supporting healthy sexual development among our young people. And so they would benefit from having these new tools on hand. Our CASA is likewise also very committed to this, and so they will have this in their hands. And then our judges are also very committed to this. And a curious story about our judges' interest in this area, they requested that in our status review reports that are provided every 6 months, that we include a special section on the social worker discussing sexual health rights with the foster youth, because they wanted to make sure that it was being done. They didn't just want to assume, they wanted a social worker to actually attest to it. And then the final slide is the path that we're looking at making this difference. And so we recognize the urgency. We want youth to have access to people who can support them, who have the awareness, who have the knowledge to do this. And we know that it's life-changing for them. And, all right. And so just to conclude, it's kind of another reflection point. And it was expressed throughout today's webinar. So our duty is to do good. It's to do no harm. And we do this through action. We do this through inaction. We do this through silence. And it could be a result of our ability, which means our awareness, our knowledge, our skills, the resources we have, and our biases. And so it's important, I feel, to make an organizational change, to have some kind of a blueprint, and to have designated stewards to move this good forward. Thank you very much.
Thank you very much, Jaime. And I think you're really making an excellent point around, Orange County has developed a very explicit strategy, and they did this before the passage of SB 89. Now with SB, and maybe some counties that wouldn't have been possible with SB 89, it's a great catalyst and rationale for bringing that group of stakeholders together and saying, how are we going to go beyond minimal legal compliance and really take the opportunity that's before us to fully implement this. So we've got a lot of information. We're now going to kind of turn to what's next. And to lead us through that conversation, I'm going to turn it over to my colleague, Carolyn Ho.
Hi, everyone. Thanks, Amy. So what's next? Like Jaime emphasized earlier, we'd love for you to use and share the resources in your county's work. These resources went through a lot of vetting and iterations, and we really hope the product is something that is helpful for you to navigate these sensitive but important conversations with youth in foster care. And so they're going to be available at the webpage link provided there. We'll also send it out after the webinar. We're also going to be working on translating them into Spanish, and that will be available in August. Secondly, JV is looking to continue to help in your county's efforts on supporting healthy sexual development among youth in foster care. So it could look like the creation of additional resources, providing one-on-one technical assistance, conducting in-person trainings, and so forth. What that will look like, we really want to hear from you. So if you can take a few minutes after this webinar to submit a response to a very brief survey, that will be really helpful for directing our efforts in this space. And so that survey link is included on there, and that will also be sent out after the webinar. Third, there is training available. Again, we don't expect practitioners or social workers to be experts, but there is training available for those who want to be more knowledgeable and comfortable with engaging with foster youth about their sexual and reproductive health. Next slide. And so Amy mentioned the components of SB 89 that we were aiming to help address with the fact sheets and guide, the informing youth portion and removing barriers. There's another component of SB 89 that requires the addition of training mandates for several professionals that work with foster youth. So CDSS was called to create a quality sexual health curriculum that covers the following topics. Number one, sexual and reproductive health rights of foster youth, case plan documentation requirements, duties and responsibilities of the case manager or caregiver, how to engage and talk with youth about sexual and reproductive health, and lastly, information about current contraceptive methods and finding referral resources for service delivery. And so who's required to be trained on this? Under SB 89, all county case managers and judges are required to be trained on these topics, and also requires that these topics be included in pre-approval training for resource family applicants, and also the certification training for administrators of SDRTPs and group homes. And so on the next slide, you'll see the various trainings that are available or will soon be. And so I'll just go over each of these briefly so you can find out when and where you can find these trainings. So like I said, SB 89 requires all county case managers to be trained. And so CDSS has created a curriculum specifically for this group, so social workers, probation officers, and public health nurses. This curriculum will be delivered in person at the 4 regional training academies as a one-day classroom training. The RTAs have all been given the curriculum materials, and they are set to deliver the training at least once by June 30th. And so the training materials are also available on the CalSpec Toolkit webpage. And so the next training available is CDSS is also creating an e-learning module that is a 90-minute version of the previous training I just mentioned. This is open for a wider range of people, so it can be for anyone working with foster youth who want to be more knowledgeable in this area. That will be available in July and will be posted on CDSS's Healthy Sexual Development Project webpage. And so we talked about how SB 89 requires the sexual health topics to be included in pre-approval training for resource families. And so county child welfare agencies, foster family agencies, and contracted community-based organizations who conduct these pre-approval trainings must update their curriculum to cover these sexual health topics. So to help with that, JBay, we're working with Seneca family of agencies to develop a brief module that can be used for this. And so once the curriculum is finalized, we will be hosting 2 train the trainer type regional trainings for those who provide, or lead trainers that provide pre-approval training. So one will be on July 25th in Torrance, California at El Camino College, and the other one will be on August 8th in Oakland at one of Seneca's training spaces. So I encourage you to please share the dates with your colleagues who conduct pre-approval training. Registration will open on June 1st, and once the curriculum is finalized, it will also be available on JBay's SB 89 webpage. That link is on the slide there. That page is also where we'll also house the new case manager and fact sheets that we talked about on this webinar, and also includes a wealth of additional information to help counties and organizations implement SB 89 and support healthy sexual development in foster care. And last one, before we go to Q&A, CDSS has created a caregiver curriculum that is a bit longer. It's about 2 to 3 hours long. This curriculum can be used by any adults who train foster caregivers, so that can be foster and kinship care educators, foster family agencies, or any organizations that conduct annual or ongoing training for foster caregivers. So this curriculum will also be covered in that in the 2 regional trainings I just mentioned. So attendees can expect a full day and take away 2 curriculums to use to train caregivers.
Great, thank you very much, Carolyn. A lot of great resources. We're looking forward to the day of training to go over the pre-approval curriculum and then the ongoing curriculum. And I think with that, we're going to open it up and have some questions. And the first one I'm going to direct to one is a comment that said the handouts are not downloading successfully. So some of you may not have been able to download those. We will follow up with the email and on the email and make sure everyone has access to them, and they are posted on our website as well. The next question we have is really about documentation. I'm going to read it and then address it. It says on CWS CMS, how much detail pertaining to the social work's discussion about reproductive health is to be documented? Given that this information is highly confidential, we wondered how much detail is to be documented in the system. Should we note at the beginning of the contact that the information is confidential? Now, I'm not going to answer this on this web seminar, but I am going to tell you that this answer you will get a lot of guidance around confidentiality and documentation at the case manager training. And again, that is required of every county social worker that has a youth on their that they serve age 10 or older. So I wish I could answer it very quickly. It is more complicated than a quick answer. But if you have young people you serve age 10 or older, a good first step is to reach out and find out when you're going to receive that training, so that you can document it correctly and know that you and really understand and have confidence in your practice. The next question I'm going to ask of you, Erica, I think you addressed it, but maybe a little bit more detail would be good too. It is, what strategies should social workers use when we have youth with sexual abuse history, or who may not be comfortable with their male or female social worker having those conversations? Should we incorporate the resource parent into these conversations?
So that's a great question, and really reflects a sensitivity towards the populations that you're working with. It is definitely the case that for some young people, they may be more comfortable with an individual who is not of the gender that was abusive or to them. I think that, what we know is that youth need a trusted adult to turn to. So the question of whether you should involve the resource parent or the CASA or the adult sibling is really an open question, or even the biological parent if they're still involved with the child and are not the abuser. But what you want to explore with the young person is there an adult who you would feel comfortable talking with about this? And how can I help you and them have this conversation? So I think it's important to respect, don't imagine what the youth needs, ask them. Don't assume that because you are of the same gender as their prior abuser that they don't want to talk with you, but be sensitive to the fact that they may not be comfortable talking with you. Find out from them who their adult resources are, and then support those adult resources to have these conversations.
Thank you very much. Here's a comment and a question. Again, I think I've been asked by caregivers that are in the process of becoming a resource parent, do they have to provide transportation to the child in placement to get access to health reproductive services, even though it goes against their values? Or can the caregiver arrange other sorts of transportation? So it is the caregiver's responsibility to provide transportation. However, of course, if they refuse, it is the duty of the case manager to ensure that that would be clearly a barrier to accessing care, and they should support that. And the role of the caregiver, the specific responsibilities of the caregiver are outlined in an excellent document that DSS has developed. Because what often happens is the question of, like, what is the case manager responsible for and what is the caregiver responsible for? And being very clear about what's on what side of the ledger is important to ensure that rights are not accidentally undermined. And so this question is one of a series of questions and topics we could bring up where it's very important to understand where the duty of the case manager starts and stops and where the duty of the caregiver is. Again, a great publication that DSS has developed to be very specific, and the training, the day-long training for case managers covers that in detail. The pre-approval training that we're working on with Seneca Center and the ongoing continuing education module that CDSS is developing also cover that topic in detail, because we don't want a situation where one group is pointing at the other group thinking that the other group did it. I would say an example of that is, many years ago, it was unclear, like, whose job was it to apply for SSI, for foster youth. In many ways, this is analogous through a law that was clarified so that the duty is very clear. Whose job is it? And that we make sure that nothing falls through the crack. I have a question for you, Erica, and Jaime, if you would follow up too, maybe sharing your Orange County experience. But first, Erica, where would you see the role of the public health nurse fitting into this process?
So again, the public health nurse is an excellent resource, and not all public health nurses are created alike. So they could have certainly have a role as a source of information, potential, as a sort of source of connection to healthcare service system that will respect the young person's rights, because also health service systems are not all created equally. You can have a wonderful pediatrician who's done a great job all through this young person's life and just doesn't feel comfortable with teenagers. And having worked in training pediatricians for many years, I can say that, with some knowledge that some people just aren't comfortable there and may not be the best resource. So the public health nurse can certainly have a role, including in a specific kind of scientific or procedural education if a young person has a method but doesn't really understand how to use it, etc. I think the most important thing is to not get caught in this kind of pass the hot potato dynamic where, no, why don't you do it? No, you do it. You're best prepared to do this. But to really take responsibility to either following through on the educational needs or assuring that they have been followed through on, not just referring to someone else and hoping they're going to do a good job.
Jaime, anything you'd like to add about the use of public health nurses in Orange County?
Certainly. So we've had a wonderful experience with public health nurses. So we have an exceptional team of co-located public health nurses with us here in Child Welfare, and they're part of our steering committee. And they are all certified sexual health educators. So this is an area of particular focus for our public health nurses. They co-lead our training to staff, caregivers, and others. They also team with social workers on a case-by-case basis, especially when either the social worker may not feel comfortable diving deeper into a discussion with a youth, or where a youth feels more comfortable with a health professional discussing youth. And we have found that many of our youth feel much more different with health professionals and much more open with them. And then the other opportunity that we have is we followed Los Angeles County's model of parenting conferences. And so we have what we call our pregnant and parenting planning conferences with our youth. And that is an ILP social worker and a public health nurse team and meet with a young person to help them develop either a pregnancy plan or a parenting plan and a support team. So yeah, that's a great idea.
Thank you, Jaime. Next question.
I'll just add, Amy, sorry, before you go on, that if you're going to enlist the support of public health nurses, who are a great resource, especially in a situation such as Jaime described, share the resources with them as well. Let them, share the sheet that you've shared with the young person. Let them see what resources the young person has already been encouraged to access, so that it's a process that is a connected process rather than a disjoint process.
Thank you very much. Another question, if a youth re-enters extended foster care, AB 12, as an adult, do we need to ask specifically about their sexual education? And no, so the short answer to that is no, that regarding their part completion of middle and high school, that is only subject to young people who are enrolled in middle or high school. The requirement, however, to inform and remove barriers is for all young people in care up to age 21. So that does include non-minor dependents. Another question, again, this is kind of a longer confidentiality one, but I want to highlight it. How do you address confidentiality for youth when information is going into the court reports? Again, the issue of confidentiality is a very important one. And the best guidance I can give you is this is a topic that's addressed in CDSS's day-long case manager training, that to really get that training and to get that information to guide your practice, because there is so much that the child welfare system is used to knowing and documenting about young people in care, and yet young people do have the right to confidentiality. And so how that plays out is important to get trained on. Next question is for you, Carolyn. How do we register for the July 25th training?
It will be posted on our JBA SB 89 page. And if you want to send me an email, I can add you to the distribution list when the registration opens up.
All right. There's more questions about transportation. Would a group home staff be responsible for transporting the youth to access birth control, abortion, and other sexual health services? Or can the youth transport themselves by bus or other public transportation services? So the placement would be responsible for transporting them. And this is a great opportunity to mention a community of practice. A number of years ago, John Burton Advocates for Youth convened 6 counties to understand kind of what the state of sexual and reproductive health was among foster youth in their counties, and to learn about how the state and counties could approach this issue. We're going to be doing something similar for group homes and STRTPs, bringing them together in a community of practice to address the very specific and unique questions that those settings experience regarding the needs of young people in their care. So to do extensive training, to revisit policies and procedures to ensure that they're aligned with SB 89, and really just to take the tremendous opportunity presented by SB 89 and by young people in these settings to ensure that they have access to reproductive health care. So that is going to be kind of announced in the second half of 2019. If you are with a group home or STRTP who feels like you may want some extra support around this issue, some extra training, some technical assistance to revisit your policies and procedures to assure they're aligned with SB 89, stay tuned for that, and we'd be very excited to work with you. Here's a kind of a comment or a question. It says, I wonder if resource parents would also feel more comfortable discussing this topic in collaboration with public health nurses. So the main requirement of SB 89 regarding resource parents is for this to be included in the pre-approval training that is required of all resource families. However, the curriculum that CDSS has developed as part of the ongoing 8-hour training requirement is also available, or will be available in July and covered at those 2 regional trainings. And so if you're welcome to include public health nurses in that ongoing training if that's it's an approach that you think would be effective for resource families in your community. Here's a comment, and maybe, Jaime, I want to maybe turn this one over to you. I'm sure that you've experienced this, at times perhaps. Someone writes in and says, we live in an extremely conservative county. How do you have suggestions on how to help staff become more comfortable discussing these issues?
Thank you. So I think the perception of Orange County is it's a conservative county, from what I hear. But that's not been the action taken by our supporters here. The first part of that is having data that is an expression of a story to discover. And so, for instance, that one data bite that over 50% of our youth are pregnant at least once before they turn 21 is eye-opening. It was eye-opening for our judges, for instance, who at first their thinking was, why do we have to deal with this among so many other things? But as soon as they heard that, they realized that and then as soon as they realized how their life trajectory changes so drastically, they were on board. And so I think having those neutral data can be a neutral way of communicating urgency and in developing action plans. So that's helpful.
So kind of focus on the facts and try and stay out of the politics of it potentially.
Yes. And then for social workers, we look at just being aware of biases, and Erica spoke a little bit about that, or not just a little bit, she spoke about it. And taking a social worker through that journey and realizing that, we're all human and we all have different, some of us can be irrational at certain times. And how do we work through that so that we safeguard our duty to do good?
Mm-hmm. I think also what we really heard with the experience of the 6 counties we worked with, that people want clarity. And that's what's so important about what Orange County has done. They're not making the call, just the individual social workers. You've created a solid set of policies and procedures. And so even if it doesn't align with your personal values, each social worker knows what their job is, and they execute that job. They don't have to, revisit, is this for or against my values? It's clear what the law is. It's clear what your policies are. And I think it gives a level of comfort and clarity around what the scope of practice is, instead of putting a person in an individual position to evaluate that. So another question someone asked about the publication that defines the caregiver's responsibility. That publication we're happy to include in a follow-up email. Which is a very, very, very good publication, lots of good scenarios around transportation, terminations, and things like that. Here's a question, maybe this will be our last one, Erica, if I can maybe hand this over to you. How do you handle, what recommendations do you have about handling a non-minor dependent who really feels like I am invading their privacy by talking about sex?
So great question. I'll try and give a 1-minute answer. Remember that you are dealing with an adult and they do have the right to make those decisions. And again, I would go back to validating their concerns. I understand you're not comfortable talking with me about this or don't feel that this really is appropriate for me to talk with you about. So let's make sure you have good resources. Who are you talking with about this? What are your resources? Are you aware of these resources on this sheet? So I think, really starting from a place of respecting the young person's autonomy. The fact that they're still engaged in the foster care system does not negate the fact that they are adults and have the right to that autonomy. So respecting their preferences, but making sure they have good resources. So even if they don't want to have the discussion with you, trying to help them get tucked in with somebody else or some other system of service where they can have those discussions. Again, their healthcare providers, particularly for young adults, might be excellent resources. So looking at, the clinics that they can access that provide sexual and reproductive health to young adults might be a great place to help them have those conversations.
Well, thank you very much for answering that. And I have to acknowledge we didn't get to all of the questions. I think a lot of them are the kinds of interesting, in-depth conversations that are going to be had in these trainings. I think this is a practice area where a lot of work is required. And so for those questions that are kind of just more factual in nature in terms of like the duties under SB 89, we will make sure to answer all of those and communicate that out, and also follow up with the presentation and all of the different web seminar links. So thank you again to all of our panelists. We appreciate your time and effort very much, and that concludes today's web seminar.